we might move on to our first speaker, who's Mr. Paul Williams, who's says postdoctoral fellow here at UQCCR. I'm one of his advisors for his PhD, so he's going to be submitting that soon. So not quite the postdoc, but he's nearly there. And he's an assistant director of pharmacy at Sunshine Coast University, Oslo. Paul is a postdoctoral fellow at UQ, as I've said. I've already talked about that before. His research focuses on optimizing antimicrobial dosing in critically ill patients. That's where he primarily works. And to improve antibiotic or antimicrobial strategies, including use of dosing guidelines, TDM, and precision dosing software.
Okay, thanks, Oz. Thanks for the invitation tonight. It's great to be here. So I'm the Assistant Director of Pharmacy Clinical at SCU, and clinically, most of my experience is in ICU. So for tonight's talk, I'll be focusing on critically ill patients and talking about the principles of dosing software. So what will I be talking about? First of all will be why therapeutic drug monitoring and an extension of that using precision dosing software, what is its place in guiding antibiotic therapy for critically ill patients. We'll briefly go through what is precision dosing software. As I said, I'm a pharmacist in ICU. In terms of pharmacometrics, that is not my area, so this will be quite basic. We'll go into a priori versus a posteriori and what the difference is between those two with an example. And then what evidence there is for precision dosing software in critically ill patients in terms of is it supported in clinical guidelines, and are there any studies to support this? And finally, I'll just finish with some practical considerations if you're looking at introducing dosing software in your hospital. So to start off, critically ill patients with serious infections, they demonstrate altered pharmacokinetics. And you can see this on the right, won't go into great detail of all the reasons, and there are many reasons why this does occur. So some examples will just be having septic shock and third spacing, and essentially hydrophilic antibiotics going into places where it should not be, increasing the volume of distribution of that antibiotic, which is risking subtherapeutic exposure. A couple of other examples would be ARC, or augmented renal clearance, which is also common in septic shock initially, which will increase the clearance of hydrophilic antibiotics, and again will risk subtherapeutic exposure. And then finally, an example would be acute kidney injury, where you will get decreased clearance, you'll get accumulation of the antibiotic, and therefore you're risking toxic exposures. So with this in mind, if you were just to dose your antibiotics in a traditional approach or via using product information, then you're risking inadequate exposure, or maybe you're risking toxicity as well. So this is where therapeutic drug monitoring comes in, and it's an individualized approach for the patient in front of you to really optimize those therapeutic drug concentrations, to minimize toxic exposures, and ultimately to improve patient care is the goal. So this approach is recommended in consensus guidelines, but in terms of patient outcomes, depending on the antibiotic, it's probably yet to be well defined across the board in a heterogeneous population. So I'm going to go to terminology just because there's quite a few terms that are used. We'll say dosing software, precision dosing software, model-informed precision dosing, all talking about the same thing essentially. So just thought I'd get that out early because I'm sure there'll be lots of terms used this evening. So if we go to the bottom left here, this is essentially my sort of basic outline of dosing software and how it works in the back end, I would say. So we start with a population PK sample, and this is essentially giving the antibiotic to a group of patients and then collecting levels from those patients to describe a population PK sample. A lot of population PK samples are from retrospective data collection, and maybe not the most robust samples, but there is a lot of variability, and it's worth knowing where those samples are derived from. But essentially from those samples, there will be mathematical models to describe the compartments and to come up with a model. So then from a pharmacometrics perspective, you'll be looking at other covariates and factors that will influence the pharmacokinetics and come up with a final population PK model, which will meet certain acceptance criteria. And this would feed into the back end of the dosing software, which in this case, we're calling Bayesian forecasting program, just another terminology. So once that's sitting there and that information's there, that prior information, it's then applying patient-specific information on top of that to help inform the forecasting software's ability to predict what dose you would be required. So that could be a simple, that can be, the age of the patient, height, weight, drug concentrations, any information about the minimum inhibitory concentration of the pathogen that you're treating. All that feeds into that. And then using Bayes' theorem, you're going to adjust the pharmacokinetics based on the individual and come up with a new dose to achieve the target that you're trying to achieve. So on the right, there's basically saying the same thing, that you start antibiotics, take TDM, you take the level, the exposure for in this example might be toxic, then you will put that into the system. You're using Bayes' theorem, it's going to update the patient's pharmacokinetic parameters and predict a new dose to maximize efficacy and minimize toxicity. At the bottom there are just some examples of dosing software programs. There are many. These are just a few. So I did say I would just discuss about a priori and a posteriori, which you may have heard of, and it's just easier with an example. So with a priori, this is not using Bayes' theorem or a Bayesian approach, but it's essentially using that population sample to predict what concentration you will achieve if you input basic information into the system. So from a practical perspective, this could be used if you had a patient that you were starting on a specific antibiotic. In this case, it's vancomycin, and maybe you want to just run a simulation to see, am I going to be sort of somewhere in the ballpark where I want to be? So in this example, we've got the age, height, weight, gender. We put in the serum creatinine, and then this case here, we're putting in a loading dose and 3 maintenance dose there, and we want the system, so the software, to tell us what concentrations we will achieve. And in this case, we're looking at AUC, assuming an MIC of 1. And that's, for this, 400 to 600. I just want to see what it get around that sort of ballpark. So if we look here, the median is here in this sort of dark blue to black color. So you can see the loading dose, the maintenance dose is there. And at this point, which is 48 hours, the screenshot I've taken is showing that 50% chance that you would achieve an AUC over MIC ratio of 626. So kind of in the ballpark, you may say, okay, I'm happy with that, or potentially a slightly lower dose, but that's an example of a priori approach. And then from there, we go to a posteriori. And this is, I've input the same information here, the difference being that we input concentration. So after that third maintenance dose, this is fictitious, I've just put in a concentration of 52 and a trough of 28. And then the software will use that to then predict the pharmacokinetics of the individual and then come up with a new dose to achieve an AUC of 400 to 600, I believe I chose. So you can see here, this is the information we put in on the left. It has plotted the 2 concentrations there. I gave it some options of what doses I would accept moving forward. And from that, it came up with a continuous infusion of 1,250 milligrams. And it expected that you would achieve an AUC over MIC of 531. So just thought I'd quickly go through those 2 examples to show the difference between a priori and a posteriori. Moving forward, the question around dosing software, is this recommended in this cohort of patients? So if we're talking clinical guidelines, it has made its way into some significant guidelines in recent years. So one here would be the Surviving Sepsis campaign in 2021. And essentially this is making a recommendation in adults to use optimized dosing strategies based on PK/PD principles. And for many antibiotics, that is inclusive of dosing software where it's feasible to use. So it is recommended there. And then the other, I guess, notable change in terms of dosing software in recent years has been the update of therapeutic drug monitoring for vancomycin for serious MRSA infections. So this was in 2020, and the previous consensus guidelines recommended trough monitoring as a surrogate marker for an AUC over MIC. But since 2020, they now no longer recommend troughs, and I'll give you an example of why, and recommend AUC and preferentially using Bayesian model and 2 samples where possible. So I just wanted to touch on this point, and this was taken from Sebastian, who's presenting later, so thank you kindly for allowing me to show this. And I just wanted to demonstrate here in terms of troughs and AUC, just from a perspective. I know at my hospital, this is a current conversation of how we monitor vancomycin, and we haven't moved to AUC at this point, and there are a lot of challenges, but it's probably worth even just this point is worth having or sharing with your broader teams in terms. On the left here, we have a C-min of 12 milligrams per liter. And I know in my practice that straight away that would be a dose increase. And I just wanted to show here, just if you did have a peak, that all these troughs intersect at 12. But as you can see, depending, well, one, how it's dosed, but also depending what that peak level is, or without further information, this could be therapeutic. So it could be 400 to 600, but without that information, we don't know if it's therapeutic, we don't know if it's sub-therapeutic, which makes it very difficult to interpret. And same on the right here, just another example where they all intersect, but this time at 20 milligrams per liter. And perhaps this is therapeutic, but also this could be risking nephrotoxicity. So I think it's a good illustration of how, where AUC has its place for vancomycin and where dosing software would have its place as well. Briefly, just to touch on any studies evaluating dosing software, and we'll go straight to randomized controlled trials. In the interest of time, I'll just talk about this one, which was looking a combination of beta-lactams and ciprofloxacin in terms of ICU length of stay. In this study, they didn't find a difference between precision dosing or not using precision dosing, but in saying that, it's a heterogeneous population. There were delays in when they utilize the dosing software. And this will be spoken about later, but one of those key advantages of dosing software is that you can take the samples before steady state. So that probably wasn't fully realized in this study. And it just raises questions too around, moving forward, and I think this will be demonstrated later today, that in the right cohort of patients, I think there is absolutely a place for this approach. But perhaps across the board in a heterogeneous population, you may not see that depending on your outcome measure. And I just wanted to mention too, just a paper on vancomycin that looked at AUC guided versus trough using dosing software. First year using trough approach, and year 2 and 3 using an AUC approach, with year 3, I believe, having optimized timing of when the samples were taken. And the main thing I wanted to just show was the violin plot on the right, which I quite like. So you can see in year 1, this when they convert trough to AUC as a surrogate, that it's quite broad, and that aligns with what we were showing in the previous slide. And as you move to the dosing software approach, you start to get this nice sort of weighting of AUCs that are more in that therapeutic range in year 2 and year 3. Apart from making nice violin plots from this data, it also reduced duration of therapy, reduced nephrotoxicity, less blood samples, and of note, and aligning with what I was saying before, when they did achieve an AUC target, that a trough concentration of less than 10 or less than 15 was observed in 31 and 68% of patients respectively, which just gives further weight that a trough approach is perhaps in some patients risking supertherapeutic exposure or toxicity. And I just wanted to finish off today just with some considerations for dosing software. There's a lot of software out there in terms of costs. Some are readily available and free, but others, there's a significant cost to them. And it's really important at your site to know which antibiotics you wish to target, or not even antibiotics, any other drugs as well, and which software include those. Ease of use and suitability of output. I think this is very important. They can get a little bit complicated, and you want it to be quite simple, and you want the outputs to be practical and helpful at the end of the bed. So that's a strong consideration. The next point, functionality subject to change. And I found using these in practice over the years that one system can change overnight. And it can take a while to get your head around that. And especially if you've endorsed a program that if you had procedures to support this, that you would need to do a fair bit of work to keep up to date with these changes. So it's something definitely to consider when you're, I guess, assessing if you were going to implement a certain program. I wouldn't underestimate the expertise, training, and support that would be required to implement this at a hospital level. And I won't go into much detail, but external validation of software and understanding the population sample, where it's come from, how it was collected, and how that is relevant to the patient in front of you are key considerations. Obviously, TDM, its availability on your site and having timely turnaround, because without this, it would be very hard to implement a dosing software approach. And moving forward, just integration into electronic medical records, or having availability on smartphones, etc., would be very handy. But at this point, I'm going to finish there, and I'm sure the other presenters today will give you some real life examples and show where it really has its place in practice. So thank you.
Thanks for that, Paul. That was really great. And I've only got a couple of questions that I've jotted down, but I might see what other people have at the end.